It's an honor to be invited to this meeting. I thought I would give some presentations on some cases where I was presented with some relatively difficult flatfoot deformities, and we'll go over, so there'll be a lot of pictures in this one, so hopefully that'll be helpful. The first study is a patient that's a 59-year-old Caucasian female, had prior surgery performed for a hallux adductor valgus deformity. And we can see a couple of problems here. One is the form of osteosynthesis. There was no form of compression here. A locking plate was utilized, and without compression, obviously this was doomed to fail. You also see recurrent deformity as well as shortening of the first metatarsal. Also on the lateral view, you can see a significant amount of deformity to the medial column, significant navicular medial cuneiform fault. And so the issue was to restore the length of the metatarsal, correct the intermetatarsal angle. The patient was not really interested in the flatfoot reconstruction. However, I did discuss an Achilles lengthening, which I thought would be effective to help restore the medial column. And so with the revision, I did an interpositional bone graft, and I was able to restore length and correct the deformity. And also, interestingly, to show the force of restoring stability to the medial column, along with an equinus release where we did a gastroc recession here. The flatfoot corrected quite well. We see restoration of Meary's angle here, and without really doing any type of proximal deformity correction like a calcaneal osteotomy or an Evans osteotomy, we're able to restore medial longitudinal arch height. Second case is an interesting one of a 51-year-old female, had a history of fibromyalgia and lupus. She had had multiple corticosteroid injections from apparent bone spurs on the dorsal portion of her midfoot. But over time, she began to develop instability, indicating a varus heel position and actually the arch height increasing. We took a look at the AP view here. You can see that the central and lateral pole of the navicular has undergone collapse, indicating the presence of avascular necrosis. And if you take a look at the lateral view, you can see the bone debris, which is fragments from the avascular bone in the central and lateral pole of the navicular. And so what the prior surgeon was doing was actually picking out these fragments, but failed to actually recognize the real problem, which was avascular necrosis of the navicular. This is a spontaneous form known as Müller-Weiss disease that does tend to occur usually in middle-aged females. In this particular instance, what happens is when you lose content to the central lateral portion of the navicular, what will happen is the talus will go into abduction and dorsiflexion, and this is what creates the varus heel deformity. And then when you lose support to the central lateral pole of the navicular, the talar head begins to plantarflex. So what you end up forming is what we call a paradoxical pes plano varus foot, where the heel is in varus, yet you lose longitudinal arch height. The surgical correction here was a midfoot fusion, and on the lateral view to the right side, you see through the lateral incision, the talus. This is how far the talus had moved into an abducted dorsiflexed position because of loss of content to the central and medial pole. And so in this particular case, we had to free up the soft tissue attachments to the subtalar joint so we could mobilize the talus and bring it back to articulate with the remaining portion of the navicular. Now, the medial tubercle area of the navicular leaves about 50% of the volume of the navicular. So in that case, we had enough to fuse the talus to the navicular. And with restoration of position, we were able to also create correction of the heel varus position by rotating the talus back into position. Did require some remodeling of the navicular itself and the talar head to get flatter surfaces. A bone hook was utilized also to rotate the talus back into position to create a mid-tarsal fusion. And in this particular instance, we were able to get excellent correction to the deformity with the metatarsal fusion. Third case is a 46-year-old female Caucasian diabetic who presents with a non-traumatic form of a midfoot deformity. You see increased swelling and erythema, which could be consistent potentially with infection. But in this particular instance, this was a form of an early Charcot deformity with a spontaneous dislocation involving the medial and central columns of the Lisfranc joint. There is potential controversy about innervating early on these in stage 1, Kindhold stage 1. Some people have the idea to go through the 3 stages and then what deformity is left to correct if needed at that time. Current thought is to innervate very early on these to prevent these severe deformities that can occur. In this case, the surgeon who had performed the procedure did restore the medial column with a spanning plate and multiple spanning screws. However, the main issue, as you can see on the lateral view, was the lack of reduction of equinus. Now, equinus is a major player in the diabetic foot. There's glycosylation of the Achilles tendon, making it stiff. And once the medial column at Lisfranc is unstable, it becomes an extreme deforming force because of the fact that it has a big mechanical advantage and a shortened lever arm. And you can see breakdown of the medial column occurring. The other issue with this patient is she was on the list for a renal transplant. She was on dialysis, and these are more difficult patients, as you know. And for her to actually be able to be considered for a renal transplant, she had to be able to walk on a treadmill. The problem is, you can see the deformity continues to collapse, and you end up with severe abduction to the forefoot, loss of medial longitudinal arch height, and the amount of abduction in this foot makes it almost impossible to really wear a shoe, and she was unable to really perform a treadmill test. So in this case, we did a midfoot closing wedge osteotomy here to restore medial longitudinal arch height and create a plantar grade foot. An aggressive Achilles lengthening was done. I do open Z-plasties on these to make sure that the equinus deforming force is rectified in any of these types of midfoot Charcots. Here you can see a strong anatomic locking plate applied to the medial column here with spanning screws, and a calcaneal osteotomy was also done along with the Achilles lengthening to restore alignment of the heel to the forefoot, and we were able to get a plantar grade foot in this situation, and then she was able to do her treadmill test. We also, as you can see, used a beaming effect on the medial column with a large 7/0 screw. The fourth case is another patient, a female patient with Charcot deformity again. And you can see here in this situation, it's primarily involving the midfoot and the cuneiform and the navicular area going all the way over to the cuboid. You can see in this situation when you basically get crumbling of those cuneiform and bones into the area of the midfoot, what it does to the talus. The talus shifts forward and down, and the patient developed a non-plantar grade foot and a chronic ulceration under the area of the talar head. This required contact casting and long non-weight bearing to get the ulcer to heal. And then she was referred for a definitive correction in the situation. She was at Kindhold stage 3 in this situation. And we can see here, we did a triple arthrodesis here with a beaming screw through the medial column and also beaming screws through the lateral column, and a restoration of stability to the subtalar joint. Anytime you deal with a situation in a diabetic with a midfoot Lisfranc, you have to extend your fusion to include the subtalar joint and the metatarsal joint itself. Otherwise, it will lead to further proximal degeneration and loss of stability. I also, in these particular instances with extensive amounts of restoration to the medial and central columns, protect these patients with static external frames to basically make sure that the patient does not cheat and start to do early weight bearing. This particular patient wasn't really trustworthy. And so in this particular situation, I did add a static external fixator. This is another instance of a Charcot deformity here in the area of the midfoot, and these are stage 3. This is the reason why oftentimes now the approach is to be more aggressive in the stage 1 deformities. Here you can see the effect of the glycosylation of the Achilles tendon, the Achilles force, how once it gets at a distinct mechanical advantage over a patient with their shortened lever arm, the degree of deformity that can occur. This patient ended up with a chronic cuboid ulceration and obviously had a non-plantar grade foot. And then she was definitively referred when she had gone through long-term non-weight bearing casting to get the ulcer to heal. In this particular instance, I did an aggressive Z-plasty lengthening the Achilles tendon, a posterior ankle and subtalar joint capsulotomy to mobilize the heel tuber. Also a Samuelson type of calcaneal osteotomy to shift the heel tuber to the weight-bearing surface. And then I did fuse the TMT45, which was the area of instability. I wasn't really concerned about the medial column in this situation, because once I had the lateral column and the heel weight bearing, I had developed a plantar grade foot in this situation. And the patient then was put in long-term protected shoe wear. These cases usually require 3 months of non-weight bearing and then 3 months of mobilization and usually a cam boot. And then they have to be in either an Arizona brace or a form of a total ankle AFO, usually for most of their life. This is a non-diabetic patient that presents with obesity. I call this a Falstaff foot, where you have multiple undulations of lipid material here. And this is a situation where you see significant instability of the subtalar joint, leading to a complete talonavicular dislocation. This is what we refer to as a spontaneous peritalar dislocation. Usually occurs in patients who are overweight most of their life. They had a flat foot from childhood, and their foot was relatively stable through their life. Then all of a sudden they notice a significant increase in pain and deformity. What happens is the supporting structures, the interosseous talocalcaneal ligament, the cervical ligament, also in this situation, the spring ligament loses its effect and the talus literally falls forward, down, and adducts and dislocates out of the mortise, creating severe types of deformities. In this particular instance, we went ahead and had to do a talectomy to restore the foot in relationship to the ankle. An intermedullary nail was utilized for a talocalcaneal arthrodesis. Also, the talonavicular joint was fused in this situation. The head was left. The body was just removed in the talectomy, and we were able to restore the forefoot to the rear foot and ankle with the fusion at this level. Also, a first metatarsal phalangeal joint fusion was done to correct the severe hallux abductovalgus deformity. This is an interesting case of a 15-year-old African-American male patient who presented with extremely painful bilateral flat foot deformity here. You can see in this situation weight bearing is a very flat looking foot, and when he stands with weight bearing, literally his talus is weight bearing and his heels are literally off the ground from severe deformity at the subtalar joint level and severe associated equinus deformity. You take a look at the lateral view, you see a significant TN fault, you see shortening of the neck of the talus, something that would be indicative potentially of a tarsal coalition. This was worked up, did not show tarsal coalition on CT scan. You look at the VP or AP view, and you see severe uncoverage angle with an increase in the cuboid abduction angle, indicating significant instability, yet you see growth plates still present, indicating severe deformity here. In this case, because he had failed all forms of non-operative care, a stabilization procedure and corrective procedure was done with an open Z-plasty lengthening that also required a bit of a posterior subtalar joint capsulotomy. The calcaneal osteotomy was utilized here to shift the tuber medially to restore the alignment of the heel to the foot level. And then at this point, because of the significance of the deformity of the medial column, a subcapital talar head wedge osteotomy was done. Care was taken not to dissect in the area of the talar neck to interrupt the blood supply at that level. And then the osteotomy is a straight closing wedge osteotomy right behind the articular surface. This leads to medial column shortening, and this restores medial longitudinal arc height. Evans osteotomies, which we're well acquainted with lateral column lengthenings, also help restore. But this was a situation of a semi-flexible foot. In other words, you had to force it back into position. And in this case, because the deformity was at the talonavicular joint itself, this form of osteotomy was performed. It was stabilized with a staple. A Steinman pin was utilized to derotate the forefoot to the rear foot because of the severe supination deformity created by long-term heel valgus and equinus and instability of the subtalar joint itself. Here's the staple being utilized for fixation, and this is the correction that was attained at the end. You see excellent restoration of the uncoverage angle between the talonavicular joint. You see Meary's angle being restored in this situation, and this patient went on to a relatively good function. These feet are still relatively stiff because of the type of deformity that is present, but they ambulate pain-free. And in this situation, we were able to avoid a fusion, which I don't like to do in somebody this age group. This is another interesting case, an old case, where the patient had an intra-articular calcaneal fracture, and a triple arthrodesis was done for this. The patient was told that the deformity was so severe, the fracture involved the joint so severe, probably a Saunders 4 in this case, that a fusion was done. The problem was the fusion was done in the area of the anterior middle facet, and the tuberosity fragment was still left unstable. This then created a severe instability issue with the equinus forcing the tuber way up because of its instability. And in this particular instance, the approach was due to correct the soft tissue deforming forces, which were the Achilles, which we did a Z-plasty lengthening, had to do an aggressive posterior ankle and subtalar joint capsulotomy. And then I did an indirect deformity correction with a sagittal plane calcaneal osteotomy to shift the tuber downward, and then do a direct bone block distraction arthrodesis in this situation to restore a plantar grade foot. A small anterior incision was utilized to obviously remove the other hardware, and the mid-tarsal fusion was left basically untouched because it was left with a plantar grade foot. This is another case where you have severe osteopenia, and an attempt of a mid-tarsal fusion was done in this situation. This is an example where you have overutilization of hardware, where you get severe compression and it leads to accretion of bone. And an equinus deformity was also present, was not addressed, and you can see severe collapse of the midfoot in this situation. In this case, the hardware was removed and an opening wedge osteotomy was done across the midfoot to restore longitudinal arch height, and Achilles tendon lengthening done, and long beaming screws done here in this situation to avoid overutilization of hardware in this situation. In this particular instance, then the graft was basically a stabilizing graft, and only one form of compression was needed through the anterior portion of the midfoot. The next case is a situation of a severe talonavicular or subtalar joint dislocation created by rheumatoid arthritis. Patient had severe pannus formation that destroyed the supporting structures in this case. As you can see here, the patient looks like it has a plantar grade still foot, but that area is the talar head in this particular instance. The forefoot lines up to the rear foot because of the fact that the rheumatoid destruction destroyed the supporting structures about the talus, and the talus literally fell out of the subtalar joint. Here you can see the significant deformity that is present, but the midfoot does not need to compensate in this case because of the loss of soft tissue support. You see the anterior translation of the posterior facet. When we did the procedure, you can see I put a laminar spreader, and the talus was like a loose tooth because there was no supporting soft tissue stabilization there, and I was able to realign the subtalar joint very nicely, fuse the talonavicular joint in this situation, and restored the position of the talus to the posterior facet. Certainly I could have considered a double fusion in this situation, but because the patient was low mobility, I felt this was adequate, and it did hold up well for him. This particular case is another rheumatoid with severe rheumatoid synovitis and another dislocation in this situation. In these particular instances, I did a medial double arthrodesis. I like to approach it through one incision because of the severe valgus deformity. Lateral incisions ended up being distracted, and you end up with wound problems. So in this approach, you're able to get the talonavicular joint, as well as you can see here, we can visualize the posterior facet of the subtalar joint, and we can get our fusion accomplished through one incision along with an Aquinas release. In this case, I like to use solid screws because of the degree of osteopenia that is present. I thank you very much for this presentation, and look forward to any questions. Thank you.